So chapter 3, elderly drug use is so huge of an issue that we have our own chapter. Because there's a lot of things that change once somebody gets a lot older. There's a lot of things we have to be concerned about. So with an aging population comes an increase in geriatric prescriptions. It's not uncommon for these people to have 3 or more prescriptions, something we call polypharmacy. Polypharmacy isn't a bad thing. Sometimes it's absolutely necessary. However, it can be bad if we don't manage it well. Aging affects all 4 phases of pharmacokinetics, our ADME, and we're going to go through each of those. So this is something that there's not a whole lot of focus on geriatric pharmacy as far as specialization. There's no geriatric doctors, just like we have pediatricians. We don't have geriatric doctors the way we should. There are some people who specialize in it, but there's certainly not enough. So as one ages, the following changes occur to alter drug absorption: decrease in blood flow to the intestines and decrease in gastric acid secretions. The big picture here, what happens is there's a decrease in absorption. Okay, so absorption goes down. Distribution, there's a decrease in lean body mass, a decrease in total body water, and an increase in body fat. So there's a slowing of absorption and subsequently a delay in drug onset. However, the amount of drug absorbed isn't necessarily affected. So drugs that are affected by the changes in drug distribution usually require a reduction in dosage. The patient may require a smaller dosage in this case. Metabolism and excretion. So there's a decrease in blood flow to the liver, which means less metabolism. There's also a decrease in production of microsomal metabolizing enzymes. Again, less metabolism is happening, so that drug tends to build up if it's not broken down. What this means to us again is that we need a lower dose, most likely, of this medication. Excretion, decrease in blood flow to the kidneys, and a decrease in all other areas of renal function. So again, this means this drug isn't being excreted. We might allow it to build up if we dose them at the same dose we've been giving our 36-year-old healthy patient. So again, we might decrease the dose for our elderly. So effects of age on drug response. Several factors are associated with aging. Nutritional status. A lot of times our geriatric patients don't eat well, they don't take care of themselves food-wise. Other disease states can affect how a drug acts in the body. And changes in pharmacodynamic responses. Again, doses are usually carefully monitored, usually reduced, because the drug just isn't processed as well as it would be in a healthy patient. Slide 10 covers common disease drug interactions in the elderly. The chart there, as you can see, let's say a patient has congestive heart failure. So let's see, let me find a good one for you. Renal disease, which is really common in the elderly. If we were to give them NSAIDs or certain medications called aminoglycosides, and NSAIDs include your ibuprofen and your naproxen. So our patients have decreased renal function. We are therefore exposing them to even more kidney damage because these medications are harmful to our kidneys and the patient just isn't able to get rid of them. Okay. So last but not least, drug compliance in the elderly. Elderly patients can be confused about their medication, especially when the number of medications climbs to 5, 6, or more tablets in one sitting, let alone 2-3 times a day. So they may need a certain little box to help them figure out what time of day to take their medications and which ones they're taking. They also may need to change in dosage form to allow for easier administration. Maybe they can't swallow tablets as well. Maybe they're just not good with those tiny little tablets, you know. It's a sort of a hit or miss thing. You have to take each of them individually and help them out. A lot of times what we'll do with our elderly patients is write on their bottles the first letter of the medication on the top of the cap in big, big black letter so they know what the medication is. They don't have to read the tiny print on the label. Hopefully they just don't switch those caps up. So polypharmacy, we talked a little bit about as well, is a concern. The book, I think, defines it as where the patient receives multiple medications from one or more doctors. It's just multiple medications. It's a situation where the patient might be receiving treatment for congestive heart failure, diabetes, gout, and now they have a ton of medications and they're just confused about when and why they're taking them. So that covers chapter 3. Chapter 4, I'll go through a few things with you. However, if this is a chapter that you struggle with, you're going to want to contact me, and I can come in and do a one-on-one or a 2 or 3-on-1 little tutoring session to help you become familiar with pharmacy math. In practice, you might be using pharmacy math, so it is a good idea to become familiar with it. After this week, you will not have any pharmacy math related questions, so now is the time to really get used to using pharmacy math. It's not that complicated. It is pretty basic algebra, which is good. However, it might be something you haven't done in a while, so a refresher is always good, and that's exactly what this chapter does. It starts off with basic math and moves into calculating doses. So slide 8 talks a little bit about, in chapter 4, talks a little bit about the systems of measurement. And there's the metric system, which is used across the pond in the UK, Europe, etc. There's apothecary, which is a super old, outdated system of measuring. And there's household, which is your common teaspoon, cup, half cup, etc. We tend not to use household as much, or if we do, we give the patient something specific to measure with, because household measurements can vary. Your teaspoon might not be the same as my teaspoon, and it's easy to mess that up. There are conversions, and they are mentioned in the book. Become familiar with those. You will see them again and again and again. For example, 5 mLs equals 1 teaspoon. 15 mLs equals 1 tablespoon. So become familiar with those and really get to know them. So, systems of measurement. A solution is a mixture of 2 or more substances. And there are several different ways that that can be measured: weight and weight, weight in volumes, or volume in volume. And I would say the most common would be weight in volume. Milligrams per ml is something you're going to see a lot. Weight meaning grams, milligrams, pounds, kilograms, etc. Volume almost always meaning something based off of a liter, milliliter, deciliter, liter. So hopefully that helps you understand that a little bit. Pharmacy math is always based off of proportions, so if you can solve for x, you will be just fine. Cross-multiplying and dividing, solving for x is something you need to be familiar with, and that is covered in these slides. Don't force yourself to memorize the pediatric dosage calculations. You most likely will not have to use this, and it's not important to have in the back of your head. So there's, I think, 3 rules there. Look at them, play with them, do a few calculations in the end of chapter questions, but don't go nuts over them. And then monitoring for IV infusion rates. Again, it's good to know how to figure out how many drops per minute you're going to be running off of an IV pump. Sometimes it calculates it for you, but you never want to rely on a machine. You want to be able to do it yourself. So again, there's a formula on slide 14, and there are questions at the end of the chapter. Definitely take advantage of those questions, and feel free to contact me should you need a little extra help. I am working this week, however, I can always meet up with you next week if need be, and we can go over that stuff in person if you need to. So that's the end of week 1. Let me know if you guys have any questions at all, and I look forward to talking to you next week.